and really thank all my seniors and colleagues for being there in this hall today, in this odd hour. So, my topic is mood swings and anxiety in perimenopause. So, I will tell about myself. Currently, I am thankful to IMS. I have been installed as joint treasurer with Dr. Sudha Sharma. Yeah, and I am the chairperson of Indian College of Obstetrics and Gynecology. And I'm so happy that Dr. Atul sir is here, who is a very senior and a past chairperson of ICOG. Okay, so mood swings and anxiety in perimenopause. So the perimenopause or climacteric is the phase of life in the aging process of women, marking the transition from the reproductive to the non-reproductive stage of life. The perimenopause is divided into menopausal transition phase, during which most women are aware of changes in menstrual flow and frequency, and the postmenopausal phase. So we know that this is that Strock classification plus 10, which explains us that which is that period of perimenopause. Okay, so we have in menopause transition also early and late. Early could be variable, but late is 1 to 3 years prior to menopause, where there is a complete cessation of periods. Now, I think our colleague Dr. Sandhya Dikshit also spoke about the brain fogging, and most of the time, most of the symptoms are overlapped in perimenopause. Some are physiological, some are physical. Physiological are anger, anxiety, depression, irritability, dizziness, difficulty in concentrating, fatigue, and mood swings. Physical are hot flushes, night sweats, reduced libido, weight gain, urinary incontinence, vaginal dryness, and bloating. I would like to share something that we have this menopausal score. So I have prepared one standee, which is there in front of my, in my waiting room and consultation room. And most of the time, the patients, antenatal patients, come with mother or mother-in-law, and the husband is also accompanying sometimes them, and they read that, and most of them then they come in and then start expressing, because they think it is normal. Then the children come and complain that my mother is getting very angry, and then they start fighting, because child will have a PCO problem. The mother starts telling her problem, then the fight starts, and she says my mother is nowadays very irritable. So that has really helped me. That 11 points, whatever score we do, I have put that. Epidemiology, it is increased in somatic, there is increase in somatic complaints, that is mental imbalance, fatigue, depression, and irritability. They were most common in women who were still menstruating. And it would present as melancholia and other types of affective disorder. Vasomotor symptoms due to the sudden dramatic change in hormone levels, that is hot flushes and all. Now this is a very big slide which talks about risk factors for depressive symptoms and depression in midlife women. Now I don't think I think anybody can go through this, but here also they have assessed the depressive symptoms and depression in midlife only. That means before they have attained menopause. Now coming to role of reproductive hormones. Estrogen and progesterone have been linked to the regulation of mood in number of different ways. Estrogen can lead to an increase in the density of receptors for a number of neurotransmitters, and estrogen enhances the central noradrenaline availability. It sensitizes the dopamine receptor and reduces the plasma monoamine oxidase activity. It can cause an increase in serotonin, that is 5-hydroxytryptamine 5-HT levels, and increase in density of tritiated imipramine binding sites, which influences the presynaptic uptake of serotonin in the brain and in platelets. That means estrogen plays such an important role at neurotransmitter level. Estrogen decreased during the perimenopause could help explain the occurrence of depressive symptoms or major depressive illness in vulnerable women. And estrogen influences the cognitive function via its effect on acetylcholine. Progesterone increases the activity of MAO. Now, plasma monoamine oxidase, that estrogen reduces that, but progesterone increases, leads to decreased levels of neurotransmitters and predisposed to dysphoric moods. So progesterone metabolized into a subtype of GABA causes somnolence, fatigue, and depression. Estrogen also play a role in psychosis. So, anti-dopaminergic or antipsychotic like action of estrogen protect against even development of schizophrenia. Now, the psychoendocrine model. In perimenopause, alterations of estradiol and progesterone, FSH and LH affects the neurotransmitter activity. Sorry. Estrogen deficiency leads to depression and schizophrenia in vulnerable women. Changes in thyroid hormone leads to changes in estradiol production, and that again leads to dysregulation of hypothalamo-pituitary thyroid and adrenal axis and causes affective disorders. And I think we do see many perimenopausal women coming with hypothyroidism. Coming to etiology and domino theory, that postulates that low mood, irritability and decreased concentration may occur as a result of the hormone-sensitive physical complaints. Sleep disturbance secondary to night sweats and irritability, discomfort and decreased self-esteem due to hot flashes may lead to psychological symptoms that can be confused with major depressive disorders, because the patient gets frustrated, she sweats so much. Psychological factors. Psychosocial stresses may include changes in family roles, children leaving, empty nest syndrome or returning home, loss of fertility, loss of friends and relatives because of illness and death, and decreased physical health. Psychiatric illnesses during the perimenopause, affective disorder. Depression is commonly associated with the perimenopause. An increase in agitation, initial insomnia and hypochondriasis with higher rates of comorbid anxiety. Because most of the time they will have so many comorbidities. They have knee pain, they have locomotion problem, most of the time now hypertension, diabetes. Women with the onset of depression during midlife may have a poorer outcome and a more chronic course compared with depressed men. So, estrogen and memory. The women who were given estrogen had a higher scores of immediate verbal memory. Estrogen appears to enhance short-term verbal memory, and these improvements in memory appear to be direct effects of estrogen rather than related to amelioration of vasomotor symptoms. Now, role of MHT. Treated women felt more composed, elated and energetic. So, an increased sense of well-being when physiological doses of estrogen are given. The progesterone may mitigate the mood-enhancing effect of estrogen. So, when these hormones are given in a cyclic fashion, women may experience a lowered mood during the progesterone phase, and that is why in a perimenopausal period, when we are giving MHT, we do not prefer cyclical, like you are giving estrogen and then adding progesterone. We give estrogen and progesterone together. Now, effects of MHT in depressed women. The role of HRT in treating major depressive episodes in perimenopausal women has not yet been well studied. There may be improvement in peri and menopausal women treated with transdermal estradiol therapy. Estradiol significantly improved depression scores in women who had major or minor depression with or without hot flashes. So, the management. Women with affective symptoms in perimenopause requires thorough evaluation of present symptoms, past psychiatric illness and personal history. Perimenopause can be documented by measuring FSH and LH levels at different intervals. HRT to treat depression basing on assessment, and patients' belief about fears, aging, femininity and sexuality also should be considered. Attention required for patient current situation, ongoing stressors, responsibility, losses and illnesses. So, if there is a depressive or anxiety symptom or in physical symptom, history and physical beliefs also take about the attitudes to menopause, current if there is any stress, and evaluation of estradiol and FSH levels. Perimenopausal, whether she is on HRT, yes, then we'll have to see her cyclical symptoms. We have to try combined continuous HRT. Try, if there is no cyclical symptom, then try higher dosages of estrogen, consider antidepressants, considering psychological treatment. If the patient is not on any treatment, appropriate biological psychological treatments are enough. If there are mild symptoms with many physical complaints, you can try HRT. If there are not many symptoms, moderate to severe symptoms, then we can give either antidepressants, psychological treatment, we can try adding MHT. Coming to biological treatments, mild symptoms, women experiencing mild depression with some anxiety, insomnia and somatic symptoms of estrogen deficiency, HRT should be suggested as the first line treatment. With moderate to severe depression or anxiety, antidepressant medication is the treatment of choice. That is, could be fluoxetine 20 mg once daily, or citalopram 20 mg once daily, or sertraline up to 200 mg once daily. If these women also experience somatic symptoms of menopause, then the use of HRT to relieve these symptoms may also help improve their general mood. Now, if there are symptoms which are caused by HRT, patient who is already receiving presents with mild cyclical symptoms of depressed mood, the relationship between the commencement of the hormone use and the onset of psychological symptoms should be evaluated. Women who continue to have somatic symptoms may require higher dose of estrogen or a change to a different form of estrogen. Sequential HRT, 14 days per month of estrogen followed by 1 week progesterone to induce withdrawal bleeding, may be more likely to be associated with periodic increase in depressive and anxiety symptoms. A change to a continuous combination therapy may be beneficial. So these are the trials done in perimenopausal women, where they found that estrogen that led to significant improvement in depression. Then again they found again the estrogen has improved. Every study they found that there was a improvement, and in one study postmenopausal, but that was postmenopausal. First two studies were perimenopausal, but another postmenopausal study there was no difference with active treatment. Both groups showed improvement like that they have shown. And then comes to the efficacy of antidepressant. We said that mild we can treat with an MHT, but moderate to severe we may have to add. So when they have added in this study, that is desenvelafloxacin, significant improvement in depression. Again there was a randomized trial. In that they did not find a significant difference, and in some studies again they found the significant difference. So psychological treatments may also be help in dealing with women who are distressed at this type of time. For women whose anxiety and they have depressive symptoms, providing correct information and eliminating harmful feels about the menopause, thereby decreasing psychological symptom. And patient support group can often be very helpful, allowing women to look at menopause in a more positive way. So in conclusion, majority of women manage this transition without difficulty. For some women, the freedom from menstruation and pregnancy heralds a time of increased independence and well-being. Women who do become depressed in the perimenopause may be particularly vulnerable to the effects of changes in gonadal hormones on neurotransmitter levels. Psychological distress may be a function of reaction to the vasomotor symptom. So there is a clear evidence of the value of HRT in the prevention of cardiovascular disease and osteoporosis in postmenopausal women. Means if we have started it in a window period. So HRT role in the treatment of depression remains more speculative. Available evidence is insufficient for recommending any botanical or complementary alternative approaches for treating depression related to the perimenopause. It is reasonable to recommend exercise in peri and postmenopausal women with depression, particularly when used in combination with recommended psychotherapies and pharmacotherapies, because that will also help her to elevate her moods and the release of serotonin from the higher center. So I think it can be a holistic approach, and that will definitely help the woman. So thank you very much for your patience here.